very excited to be doing this together with Columbia and with the Department of Kidney and Pancreas Transplantation. And we also want to thank Veloxis for sponsoring this series of educational seminars. We are motivated to do this because we believe that education empowers patients. The more we can learn about our own conditions, the more we can ask questions, and the more we can feel in charge of our own healthcare. I know this firsthand. I'm not only a physician and scientist, but I'm also a person living with a chronic disease. It happens to be kidney disease. I have gone through a kidney transplant and a pancreas transplant. So to me, this is personal as well as professional.
The kidney has several roles. One, it regulates our fluid balance, and so we take in extra salt and water, and whatever our body doesn't need, the kidney is able to excrete in the form of urine, of course. In doing that, it also regulates a lot of the mineral content of our blood, so that our potassium doesn't get too high, or our phosphorus doesn't get too high, or our calcium levels don't get too high. So it's clearing out a variety of waste products, as well as excessive minerals and salt and water. And its third function, in a sense, is it helps regulate your blood counts, prevent you from becoming anemic. So it's doing quite a bit in a small package. If any of those go awry, then you have kidney disease in one way or another.
Ordinarily, with adults, the primary cause of kidney disease is usually some sort of metabolic issue, primarily diabetes, hypertension. But with children, they tend to present when they're either, we've already known prior to their being even born during prenatal exams, that they may already have a congenital issue with their kidneys. And for the most part, about 50% of kids that have chronic kidney disease have some sort of congenital issue. So that might be already known or caught early due to infections of the urine. We might also find out from having screens with their doctors that there's some protein or some blood in their urine, and that's also a reason why they'll be sent to us, in addition to being evaluated for reasons for having high blood pressure.
You know, we like to start evaluating a person for a transplant when their kidney function or their GFR is around 15 or 20% of normal kidney function. Most people don't really need to be transplanted until they're down around 10 to 15% or GFR. But certainly there are things that people could do to slow the progression of kidney failure. You know, one of the things that happens is that as the kidney is damaged, as the little micro units in the kidney are damaged, the ones that are remaining have to work harder. And by working harder, they sort of get worn out. So it becomes a vicious cycle after you get down to the point where only about 1/6 of kidney function is left. So I'd say if there's a point of no return, it's probably about, you know, when you're down to 1/6 of normal kidney function. But again, that could be delayed by diet, maintaining proper blood pressure, things like that. Let's talk about right before the pandemic, because the pandemic screwed everything up with transplant. But right before the pandemic, in 2019, 41,000 people in the United States were newly placed on the waiting list for kidney transplants. And there were about 23,000 kidney transplants done. So we're falling about 20,000 transplants short per year. So because of that, anyone who's, you know, going to need a kidney transplant, they basically have two options. The first option is go on the waiting list and wait for a deceased donor transplant. And that, depending on where people live and what blood type they are and whether or not they have antibodies and a whole host of other factors, will influence how long they have to wait. And the waiting time could be years. Or the other alternative is to get a living donor. And a living donor doesn't have to be a blood relative. It doesn't even necessarily have to be someone who's of the same or even a compatible blood type. So there are a lot of options with living donors. And in fact, one of the things that we've seen is the number of people who just want to donate a kidney and don't have a particular recipient in mind is increasing. And again, to put the numbers in context, in 1999, there were 5 what we call non-directed donors. Those are people who just come forward, happy to donate to anyone in the whole country. And it was front page news on the New York Times. And they profiled a patient of mine. And so I have the picture, I have the article hanging in my office in a nice framed display. 20 years later, there were over 450 people nationwide who came forward and said, I'm willing to donate to just anyone. So a 90-fold increase in 20 years, which is extraordinary, but we need like another 90-fold increase.
So we usually have to restrict salt and potassium in addition to phosphorus around the time that people are getting started on dialysis or need a transplant. And that's because those are things, as Dr. Cohen had mentioned before, that are typically monitored and excreted properly by the kidney. And in those situations, a nutritionist is very important. In our clinics, we often send our patients to see a specialist on nutrition in addition to counseling them in the office themselves.
So as I understand it, they really shouldn't eat tomatoes, bananas, because they have a lot of potassium, or a lot of cheese. Because
coconut water, plantains, things like that have a lot of potassium in them.
And having gone through this, I can tell you that when I was just pre-transplant, I was told that I could hardly eat anything. And that is an absolute nightmare, right, for a person who is also trying to function. The diets for kidney people, I think it really needs to be assessed and thought about from a quality of life perspective. When you're told you can have protein the size of the palm of your hand, you cannot drink so much, you cannot have any potassium. There's so many things that are restricted because fatigue is one of the biggest issues for a kidney patient. And if you restrict their diet and their fluids, they get even more fatigued.
People get sort of from their physicians a lot of offhand dietary advice. For the kidney patient, limit your protein. For the diabetic, limit your carbohydrates. It is important to have good and organized and specific counseling about what you can actually eat, because unfortunately that sort of advice is obviously not really possible for anyone to obey. And then the patients are confused, and then they go back to eating what they want because they haven't been really given very useful information.
The first thing people frequently ask is, they're concerned, is it going to be safe for the donor? We put the donors through very extensive evaluation to make sure that it's going to be safe for everyone involved. And that takes time. Getting involved early gives you the time, and not everyone who wants to donate a kidney can, because it's not going to be safe. And also there are plenty of resources where people could help you in terms of the ask. There are organizations that actually have programs for asking donors and to provide for recipient advocates so that someone else could potentially ask the potential donor, so that it kind of removes the recipient from that mix. Let's say, you beat up your younger brother your whole life when you were kids. It's tough to go ask him for a kidney, but someone else may be able to ask him, and he may actually be willing to do it. There are different cultures have different ways of asking. In the Hispanic community, I'm told that the grandmother is often the right person to do the asking. In the Orthodox Jewish community, there's an organization called Renewal, which is very effective at helping people find living donors. And we've even had people who found living kidney donors by posting flyers in a laundromat. I'd say cast a wide net, do it as early and as often as possible.
The things that we're looking for are really how well the patient's doing. If the patient's not feeling well and their kidney functions now drop below 10%, then it's a question of what's the timing, what kind of time do we have? If the patient's acutely now doing well and is showing signs of like nausea, fatigue, severe fatigue, and it's not able to be medically managed, that means we can't adjust medications, we can't change the diet, then it's time to proceed with either doing dialysis or moving very quickly for a kidney transplant. Now, the kidney transplant process can take some time from a living donor. So if you haven't already put things in order, then it might take, you might be on dialysis for a bit before you get that transplant. So things that specifically that we look for are signs of on physical exam. Some people start to get some unusual shakes and tremors. They may show some swelling in their legs that is getting out of control. They're starting to have fluid in their lungs. Those are all physical signs that they're starting to really need dialysis in order to feel better and to continue. We like to have somebody there as a support. And that person is very important. If it's your parent or if it's your spouse or your significant other, in order to help to have another head that's looking at these medications. Often what we see in young adults is that that parent has now decided that their child is ready to take care of themselves, and they may leave them to do their own thing, and they're not ready for that responsibility yet. So having a second pair of eyes. We also work in a multidisciplinary group where we have a pharmacist that meets with our patients, again, regardless of age, to go over the medication adherence, to go over what medications that they're taking. Maybe they don't understand all the ins and outs of their medications. And when we call to make adjustments, maybe there's some miscommunications going on. We monitor the levels of the medications very carefully. And that is actually very new to a lot of our patients. They're not used to taking their medications exactly the same time, twice a day, for the rest of their life. And I think that's the biggest adjustment. I work with a young population, and adherence is a big problem. So I think that just learning to take your medications appropriately, knowing how to get your refills and everything, we try to teach that to our patients first. And then in regards to the monitoring of the levels, you partner with your doctors, you make sure that you get your labs done at least monthly or every other month to make sure that your kidney function is doing well.
Every center is going to have different requirements in terms of the number of support people. Frequently, you might see that they request a primary caregiver who can assist with transportation to appointments, reviewing medications, making adjustments, and then a backup caregiver just in case that primary caregiver is not available. And also just offering emotional support through the process as all of these adjustments are going on, as one is recovering from surgery and adjusting to all of these medications, going to all of these appointments, and kind of adjusting to this change of life that's come after the transplant. So it is something that wouldn't hurt to start thinking about at the time that one is told that they have kidney disease. It also might be helpful to think about potential caregivers.
I would add one very important thing, which I think it's crucial for the person with the kidney disease at any stage, and certainly with a transplant, to feel like they are partnering with their physician. And that means both that the physician, which of course we do all the time, is we're telling the patient what we expect. But it's also very important to allow room for patients to express when things are difficult, when they're having side effects from the medicine, or the medicine's expensive, or somehow there's no one to go to the pharmacy to get the medicine on their behalf, or it's very difficult to get to appointments, or if they anticipate any of those things, that they share that, and then a solution is worked out together, rather than just not showing up for appointments or keeping those things because maybe people are ashamed that they can't afford the medicines or something. But establishing a relationship where those things can be discussed openly and worked on, so that the long-term success of whatever treatment it is at the highest level possible.
Everyone's a little bit different. People who use their brain a lot for whatever work they use say how much clearer and sharper they think. I've had patients who are practically suicidal from the itching that they had, and that cleared up within a matter of hours. The fatigue gets better. So almost all the symptoms of, advanced kidney disease get better within relatively short order after a transplant. And it's really remarkable how much better people feel. And in fact, we have some patients who, because kidney disease could be very indolent, it could creep up on you over a long period of time, and you kind of adjust to the way you feel. I've had a lot of patients who say to me, I didn't even realize I felt bad until I got the transplant. And now I feel so much better that I realized I felt bad beforehand. So it's quite a diverse mix, but almost everybody feels significantly better, very shortly, within a matter of hours to days.